and not too much time, less time now. So in order to kind of be able to cover as much content as possible, I'll try and keep detail reasonably exam focused. I won't be going into too much detail in terms of anatomy, pathophysiology, etc. And I'll try and keep things exam focused. Personally, I like to keep things exam and OSCE focused because I think that the OSCEs are a good way to study for your written exams, and a lot of the stuff that you learn in learning OSCEs tends to be quite relevant for your written exams. So this stuff will be pretty useful for your histories, etc., because I mean, you can't really do exams over Zoom. And a lot of that will hopefully be applicable to your written exam. And yeah, hopefully it'll keep you awake. So let's go through a couple of things. I'll have a couple of these learning points throughout the presentation, because just to kind of like keep you guys awake and also make sure that you know some of the important stuff, and some tips and tricks in terms of keeping things relevant for actually performing well in exams. In third year, as you've probably been told by Michelle Leach and faculty, your main concern should really be on diagnosis plus investigation. You don't really need to worry about management too much unless it's a real bread and butter condition, like your classic ones like ACS, pneumonia, and then asthma, that kind of stuff. So really focus on investigations and diagnosis, because I remember last year in our exam, we, for some reason, had a ton of investigations questions, which is quite mean, but it's something that you should kind of come to expect. So keep an eye out for those kind of things as we go through. All right, so let's get started. First things first, we are going to look at hepatobiliary before moving on to the different parts of GIT. And I will quickly share this. All right, everyone quickly join this Kahoot. I'll give you guys like a minute or two to think of usernames, and then we'll start. This will just be running throughout the whole thing because I've got a few questions to try and keep it exam relevant and also keep you engaged. I think I'll turn, yeah, no, I've turned the music off because I swear to God, if I have to listen to Kahoot music this early in the morning, I will not make it through this lecture. Oh, look, that's me. All right, I'll give you guys another couple of seconds. All right, awesome. Oh, no, there's still more coming. 5, 4, 3, 2, 1, and all right, let's get going. I haven't run a Kahoot since first year, so let's hope this goes smoothly as well. All right, so give us a diagnosis for this condition. Actually, we'll turn the music up a little bit. Cool. Awesome. Okay, nice. Looks like I kept it pretty easy. Viral hepatitis. Let's go firstly through a lot of your viral questions and focus on those, because those are classic exam style questions that you guys will get a lot. So there's mostly like a couple of different types of hepatitis that you need to know quite well, but in total there are hepatitis A to E, obviously. So let's quickly go through some of the main things you need to know. A lot of these slides I've covered kind of the entirety of the matrix condition, all the different factors that you're going to be aware of. However, out of all of them, the parts that I've highlighted in that light kind of magenta red are the most important things that you're going to need to differentiate between other conditions. Because let's be real, at the end of the day, when it comes to exams and OSCEs, chances are that you guys will be able to narrow it down to 2 or 3 conditions. And then the hardest part will be getting that kind of like final decision between a couple of answers at the very end. So first things first, let's look at hepatitis A and E. Hepatitis E is not very important, but hepatitis A, you should know to a very kind of small degree, especially in terms of just the buzzwords. So hepatitis itself is quite easy and shouldn't be too difficult for you guys to diagnose, as we've seen in that question. So with a bit of practice, you guys will get quite used to it. You're really looking for your jaundice, pruritus, dark urine, pale stools, and then maybe some of your fever symptoms. And that's kind of the entirety of viral hepatitis. Differentiating between the types is sometimes asked of you in exam questions. And the way to do that is really to keep an eye out for risk factors. So I've highlighted some of the common ones for hepatitis A. People from Asian countries, contact with children. It's mostly a fecal oral transmission route, which is very different to hepatitis B and C, which are blood-borne. So keep an eye out for those kind of things. In terms of investigations, an ALT over 1,000 is like your classic hallmark viral hepatitis result. So that's something really important and exam relevant to know as well. So yes, as I said, when it comes to diagnosing hepatitis, really just firstly focus on diagnosing actual hepatitis, because the rest will really just rely on buzzwords or investigations. So once you have those infectious symptoms plus your classic associated with jaundice symptoms, that really indicates that you're dealing with a viral liver condition. All right, another question it looks like. So let's go. Almost everyone. Nice. Well done, guys. So this is something else that is quite important when it comes to your hepatitis kind of stuff. So let's take a very quick look. This is very relevant to hepatitis B, and this is the one that you usually get your serology questions for. Don't really often get serology questions for Hep A, Hep C. It's much more rare. So hepatitis B and C, as I've said, are blood-borne, which is different, very different to hepatitis A, fecal oral. Important things to remember with hepatitis B are your risk factors, once again, for differentiating, which is sexual contact, IVDU, as well as, those are the main ones. And then secondly is the kind of progression from hepatitis B. It's not the most likely condition, but it is one of the conditions that can potentially progress to a chronic infection and then cirrhosis and then hepatocellular carcinoma, which is kind of a stepwise pattern that you'll often see in questions. Hepatitis B, as I said, isn't the most common for this kind of pattern. It's hepatitis C, but it's still important to consider it whenever that comes up. Clinical presentation, once again, is very classic hepatitis, viral hepatitis, but it's super difficult to differentiate based on that. So once again, we'll be looking at investigations. In this case, you'll be doing a hepatitis B serology, which is probably one of the more common hepatitis tests, and hepatitis B is one of the more common types of hepatitis that you guys will have to know, not only this year, but in 4th year as well. So there's a few different types of antigens and antibodies present for hepatitis B. I haven't listed all of them here. I've just listed a couple of the general ones that you should know. So HBs antigen is the one that indicates that you currently got a presentation. Then you've got HBs antigen and HBC antibodies, which you guys know about, it seems like, from the quiz question. So HBC antigen antibody is your core versus S represents your surface. So depending on your previous exposure to hepatitis B, you could have either the core antibodies or the surface antibodies present. Then you've got a couple of like weirder ones, which are HBV DNA, which shows your viral load. As the infection progresses and becomes more severe, your viral load will go up. And then your HBeAg is a representation of how your viral replication is going. Otherwise, that's pretty much all the important stuff for hepatitis B. As you might have noticed, I haven't really covered management in too much detail because this stuff doesn't really come up for hepatitis B. It is important to know that I guess you treat it with antiviral therapy, and that in some cases you might do some other imaging. But for the most part, it's a notifiable disease, and just know that you'll manage it with antivirals. This is a very quick table showing just the basics of your antigen and antibody and how to differentiate between different types. So this will all be on the slides that you guys can look at later. But as we saw with vaccinated, you've got negative for your surface antigen, but positive for your surface antigen antibody. Versus the next one to look out for is when you've got a past infection, so you're immune, then you've got a positive antibody in both cases to core and surface. All right, keeping things moving. Next is hepatitis C. As I said, another very classic presentation that you guys can get in exams, and this is your most common form of chronic hepatitis, and it is the most likely to present to HCC. In a lot of cases with hepatitis C, Monash will like to give you a kind of IVDU drug user as kind of the transmission method, but still just keep your eyes out for things like needle stick injuries, tattoos, etc. Investigations, you'd like to pretty much always do a HCV and a HIV serology. Your HCV serology is important to just determine the state of the hepatitis C virus in this patient, and the HIV serology is because they're commonly kind of co-infections, so you want to know what's going on in both cases. Cool. So just a bit of a crude method for remembering hepatitis A, B, and C. A, classically Asian countries, people who are coming from overseas, or people who have, like, the classic is like goes to Bali, that kind of thing, and then eats a lot of the street food, something along those lines. B, sexual transmission booty. C is cocaine drugs, and C for chronic. So it's an easy way to remember the different types. All right, next question on to Kahoot. Oh, I don't know if you guys can see, so I might zoom in my screen a bit. This is a tough one. All right, I'll just read it out in case people are having trouble seeing, but 19-year-old girl presents with jaundice, fever, malaise of 1 week duration. She has no history of blood transfusion, piercing, or tattoo. She's single and states she's not sexually active, but she stays in a hostel and often eats out. On examination, she's febrile, jaundiced, and has mild pain in her right hypochondrium. So febrile and jaundiced and malaise of 1 week duration are the main symptoms. Not going to hint at it too much, but that should help out a bit. All right, almost everyone. Cool. Excellent. So this was a bit of a harder question, a lot more things to consider, and a lot more information for you guys to look at, but still something that pops up quite a bit on exams, so it's definitely good to know as well. So this is kind of a very brief overview of what kind of findings you'll see on an LFT, and it's really important that you get good at interpreting LFTs. So just take a look at this table sometime after the presentation, try and memorize some of the main things. It's almost like a buzzword table, honestly, so this stuff is pretty classic. So most of them are things that you'll have seen before as well. Oh, sorry, I didn't realize there was another Kahoot question. These are surprising me too, guys. Like, I don't remember what I was doing last night. All right, here we go. So for this question, think about not only what is present, but what's omitted. Awesome, good work. So next kind of important thing to know when it comes to hepatobiliary is really your like non-viral infection liver conditions. So the first one we'll look at is non-alcoholic fatty liver disease. Literally the disease, like pathology is in the name. It's non-alcoholic and it's fatty liver disease. So the classic things that you're kind of looking out for, especially on pathology, are hepatic steatosis, so your fat globules, inflammation of the liver, as well as fibrosis. Classically, they'll also have your history of diabetes, obesity, hyperlipidemia, and no alcohol or no significant alcohol history is really important as well, because that's kind of your differentiating factor on history between NAFLD and AFLD. In terms of your clinical presentation, it is a bit hard to get just from history, but you kind of get it in the description with a high BMI, etc., plus your hepatomegaly, and maybe some signs of cirrhosis depending on the severity of the condition. The important stuff is your investigation. Now, liver ultrasound, like a fibroscan, is kind of a classic thing that you might do in clinic, but the most important thing is pathology here. And this is a condition that you guys probably learned in PAP. I know everyone hates PAP, but it's definitely kind of important for GIT and hepatobiliary, as well as just kind of getting used to the classic findings. So steatosis, inflammation, and fibrosis, start thinking AFLD and NAFLD. And then your management is super easy, just focus on lifestyle. In contrast, alcoholic fatty liver disease, once again, it's literally in the name. It's your most common cause of liver cirrhosis, and it usually involves someone who's a heavy drinker. I've included some of the kind of guidelines for your classic heavy drinker numbers for men as well as women. And it usually is a long history of really heavy drinking. So your clinical presentation will be very similar to non-alcoholic fatty liver disease in terms of actually like liver symptoms, but you might notice a couple of other things solely due to the alcohol. Heavy drinkers will classically have things like enlarged parotid glands and palmar erythema. Those are the like big things to look out for, as well as malnutrition. And depending on the severity, you might see portal hypertension, but it's not the best differentiator. Investigations, classically on LFT, if they're a heavy drinker and they've just been drinking acutely, you'll see a raised GGT. But overall, if you have AFLD kind of longer term and they haven't been drinking too much recently, your AST to ALT ratio is above 2. And then once again, biopsy is what you're looking for. Similar to non-alcoholic fatty liver disease, but there are some buzzwords such as Mallory's hyaline within liver cells. If you look for kind of Mallory bodies on your pathology, kind of sections on your exam, literally if you see Mallory bodies, work out if they're saying no Mallory bodies or Mallory bodies, and then choose AFLD or NAFLD. That's pretty much all there is to it. Cool. Oh, sorry, someone's just asked in the chat. So for males, that's 12 standards per week, and for females, it's 14 standards per week for like your super heavy drinking. Good question though. Sorry, it wasn't too clear. I've gone a real shorthand here to fit it all on the one slide. Management, honestly, just stop drinking at that point. Like do your kind of classic counseling, stop alcohol. That might be something to consider in an OSCE, actually having to counsel them on their drinking. And then the main pharmacological thing is like corticosteroids, but otherwise a transplant is what they'll really need once it gets to bad cirrhosis levels. Awesome. So yes, these two are very common PAP questions. So make sure you learn some of the buzzwords, as I said, for AFLD and NAFLD. And then these are a couple of smaller alcohol-related syndromes. I'm not too sure if someone else might cover them, but I think it's good to mention. Super buzzwordy. Wernicke's is when you've been drinking pretty heavily. You have confusion, ophthalmoplegia, and ataxia. I mean, just think about the last time you were drunk. And then Korsakoff syndrome is very, very severe alcohol dependency. So people have memory loss. They have confabulation, which is literally kind of a psychiatric presentation where they're talking nonsense kind of, and ataxia as well. And this is irreversible. So in both cases, it's usually due to a vitamin deficiency from alcoholism, and you literally treat them with thiamine in order to kind of reverse these changes in Wernicke's, not really in Korsakoff's. Next Kahoot question. Dun, dun, dun. So what is the treatment of choice for this situation? Almost the last few people. Awesome. And acetylcysteine. Nice. This is kind of something niche you probably, oh, whoops, I wasn't meant to click next. Sorry. Let's answer this question too. I feel like you'll mostly get it from the tan. Awesome. Hemochromatosis. All right, let's go through these. So there's a couple of things to be aware of in terms of chronic and acute liver failure. Firstly, let's very briefly look at acute. It's not something that comes up too much, but it is something that does come up on, or has come up on OSCEs. So just keep an eye out for it. Acute liver failure is when you do something to really acutely screw up your liver, like similar to an AKI, except it's your liver. There's a few different causes, with some common ones being your medications, drugs, but also things like shock and Wilson's disease in some cases, but those are less rare because you don't need to know as much about them for third year, especially Wilson's disease. You should know shock. In terms of the clinical presentation, the main thing to look out for is a real confusion/delirium picture. You really get patients presenting to you who are really drowsy, lethargic, ataxic, not really oriented to their time and place and that kind of thing. And then you'll see some other symptoms that are classic for acute liver failure, like you'll see like a pretty fast onset of jaundice, as well as asterixis. So in your GIT exam, when you do asterixis, you're actually looking for acute liver failure because essentially there are compounds released by your liver during ALF that affect your brain, as well as your ability to kind of hold that position in asterixis. So on your investigations, you want to do a full-on screen for everything: viral hepatitis, LFTs, coag studies. Actually, I won't ask a question because it's a bit weird on Zoom pointing people out, but coagulation studies, as most of you hopefully know, because a lot of those compounds that are important for coagulation cascade are made in the liver, and then a liver biopsy if necessary. In terms of the management, the main things to do are really monitoring and all these tests to narrow it down, and then you'll treat depending on the etiology. But for paracetamol overdose, and acetylcysteine is your classic. So if you get a delirium station, keep acute liver failure on your differential list just because of a confusion-like presentation, just so you're aware. Cool. So next we'll take a look at liver cirrhosis. So I'm just getting a couple of questions privately messaged in the chat. I'll keep going for now just because I'm wary of time, but I'll try and get to them at some point. Liver cirrhosis. So liver cirrhosis is your chronic liver disease. And its main thing to really know is that it's irreversible. And this is the kind of stuff that you'll see on a pathology exam once again: really heavy fibrosis and really irreversible nodule formation. So it commonly precedes your hepatocellular carcinoma. In terms of your clinical presentation, once again, it can be a bit hard to kind of differentiate solely based on history, but on an examination, you'll usually see some pretty classic signs of an irregular nodular hard non-tender liver when you do your palpation for the liver. And then you'll also see things like portal hypertension, which is a bit more of a late stage symptom, spider nevi, clubbing, and in men you can see gynecomastia. If they're alcoholic, you might see Dupuytren's. So there's a few symptoms that you'll classically see on an examination with someone with cirrhosis. Maybe you might have even gotten to see someone with cirrhosis during your time on the wards this year. In terms of your investigations, once again, AST to ALT ratio is the main thing that you're really looking out for. And you're also a bit worried about things like hypoalbuminemia, because that can kind of proceed to give you some other symptoms like edema, etc. You want to do things like coagulation iron studies, as well as, coagulation studies, because as I said, your coagulation cascade is made there. And then also consider doing an alpha-fetoprotein. This is kind of a buzzword, but it's an important buzzword to know for any kind of liver cancers. So keep an eye out for alpha-fetoprotein. Management isn't too important. So going on from cirrhosis, portal hypertension is another classic, like late stage severe liver disease presentation. It's important because it can cause some of your other GIT presentations, and they all come under the umbrella of portal hypertension. Essentially, you start to form what's called portosystemic shunts, commonly from like really severe liver disease. And the classic locations of these are around your kind of esophageal sphincter, as well as around the anus. So your presentations that you really need to watch out for are hematomesis and PR bleeding. So essentially, those are the two most common sites of your portosystemic shunts. And then your other like general cirrhosis symptoms plus Kappa medusae and ascites. Kappa medusae is when you have all these like blood vessels that you can see on your tummy, kind of looks like a Medusa head. And then a little acronym for this is Harvey. So if you kind of expect in portal hypertension, which as I said, late stage, to see encephalopathy, which is your confusion and stuff, ascites, renal failure, and then variceal bleeding is your real classic one, plus iron deficiency anemia due to blood loss. Those are your really key symptoms for portal hypertension. Awesome. Okay, I think we're up to the next question in this Kahoot. I've lost track now, but let's go. The speed of the first answer is a good indicator as to the difficulty of a question. So this is straight out of an exam. So this is a guy presenting with fever, right upper quadrant pain, tachycardic and hypertensive. White cell count is high. Lipase is within the reference range. And there's fat around the gallbladder. Nice. So good kind of differentials, everyone. We'll go into a bit more detail about cholecystic diseases, just gallbladder related stuff. So firstly, this was a hemochromatosis question. We've already done it. So high iron levels, if you see bronzing of the skin, it's not a tan, it's hemochromatosis. You classically see other kind of symptoms in stigmata of liver disease, and a classic association is your dilated cardiomyopathy. So keep an eye out for that whenever they do an echo for someone who might have hemochromatosis. And in terms of your buzzwords for pathology, obviously your iron studies are important, but your Pearl stain is the one to look out for. This is a question we just did. Yes, now we're up to date. So cholecystitis is a classic presentation, and you guys need to really get to know all the different kind of chole something diseases. So with cholecystitis, essentially it's inflammation of your gallbladder due to cholelithiasis. We'll go into the definitions in a second. The most common kind of stones to watch out for are cholesterol and then pigment. Cholesterol is the more common, you should know. And the classic risk factors are female, fertile 40s fat, so the 4 Fs. in terms of a clinical presentation, you've got your severe right upper quadrant epigastric pain as well as Murphy's sign. And then in some cases, you can also have anorexia, so not really feeling like eating, and then a fever. And on investigation, the main things you're really looking out for, Monash just loves to give you LFTs. So if you see a high GGT or an ALP, as the kind of table showed a few slides back, that's just a classic cholestatic picture. But I mean, the most common kind of thing you might do is really just an ultrasound because it's quick, it's easy, you can do it in clinic. But Monash isn't always super clinically relevant when it comes to it. And then here's a tiny bit on management. So these are some of the general like cole stuff, things that you guys should know. Biliary colic is arguably kind of a symptom, but it's your colicky pain after fatty food in the similar location as where your gallbladder is. Cholelithiasis is just the formation of gallstones, and it's asymptomatic in early stages, but as you form more gallstones and as they eventually block off the ducts, then you'll start to get cholecystitis. And the main thing to note with cholecystitis is just differentiate based on pain. So if you've got pain, then you're thinking cholecystitis, cholangitis, etc., or biliary colic. If you have no pain, then keep an eye out for Courvoisier's law. We'll go into that in a few different sections, I think, a bit later. But that's your jaundice but painlessly distended gallbladder. So if you've got stones in it and it's swollen up, your gallbladder is going to be painful. Choledocholithiasis is specifically obstruction of the common bile duct. And in this case, you've got jaundice, pruritus, ducts, urine, and pale stools. So it's classically that kind of presentation. And for cholangitis, the main things that you'd be looking out for are Charcot's triad, right upper quadrant pain, fever, jaundice, and Raynaud's pentad. I think I've spelled that wrong, actually. I think it's Raynaud's, but essentially adding hypotension and tachycardia. So for people who, I honestly don't remember what the question asked. I don't think I can go back in this, can I? No, I can't see the question, actually. Oh, okay. So what question did we just do? We've done 7 questions. Can I see the picture? All right, we just had a couple of questions in the chat, so I'll go over this very briefly. The main things to look out for are, oh, looks like that was my bad on my end. I would say that this is more likely to be cholangitis because of the tachycardic and the hypotension. For some reason, I think I just threw that into the answers and then it wasn't an answer in the original exam question. So that is a bit confusing. Sorry, once again, 2 a.m. job. But for the people who answered cholangitis, I would say that if that wasn't an answer in these options in an exam, that would be your go-to. If it wasn't, then cholecystitis would be your best option. But I stupidly put both into this question. I would say the more correct answer would actually be the cholangitis. All right, back to it. So before we finish off hepatobiliary, these are just some of the questions to look at, some of the buzzwords, sorry, to consider. Okay, sorry, getting more questions privately in the chat. Cholangitis without jaundice, though. So you'd expect jaundice in either situation, but the tachycardia and the hypotension, importantly the hypotension, that's kind of your shock kind of picture. Once again, these exam questions haven't been given answers. I'm literally just going off my own knowledge as well as like Kami and stuff. So take it all with a grain of salt, not only during my presentation, but everyone's. I would lean more towards cholangitis for the people who have asked questions. Yes, the guy doesn't have the jaundice, but whenever you've got your tachycardia and hypotension, it's more likely to have kind of that septic picture with cholangitis infection rather than cholecystitis. Someone just asked for context whether you'd expect cholangitis without the jaundice, and someone else asked whether it's more likely to get, whether it would be cholangitis. Cool. Yes, you would get cholecystitis. I'm sorry, Charcot's triad with cholecystitis, similar, but not all the way. You wouldn't get like as many fevers and stuff. So you'd still get the right upper quadrant pain, but without the feverish symptoms, which is more so indicative of infection. All right, I should take a break from answering everyone's questions. Please feel free to message me on Facebook, just because I rocked up late and I'm wary of time. So I'll keep this moving, but shoot me a message on Facebook if there's anything that you're not 100% certain of. These are some buzzwords. I'm not going to go through all of them. You can look at the slides later. But the main things to look out for, these bottom three here are real classic like PATH presentations. And yeah, those are the main things that you need to watch out for. And these buzzwords are pretty accurate, like high sensitivity, high specificity buzzwords. So you should be pretty good using them. Awesome. Now that we finished hepatobiliary, we can finally move on to upper GI. I'll try and move a bit faster because I want to get through this presentation without running into your break, which I think is a break afterwards. So let's keep rolling. First things first, something that isn't too important is your motility disorders plus achalasia. Essentially in these cases, you're having trouble and your classic presentation is dysphagia. So you're having trouble passing food through your esophagus. The main things to note are that you have a slow onset of dysphagia as you're eating, and then these kind of conditions are classically eased by standing up and moving about after eating, depending on the presentation. So if you have chest pain as well, consider an esophageal spasm, but really the buzzwordy kind of stuff to know is your investigation results. So on achalasia, you would see esophageal dilatation plus a rat tail sign. So that's because your esophagus is going down. It's dilated because you've eaten a lot of food and it hasn't passed through. And then a rat tail at the very end because something is kind of constricting it at the very end. So that's kind of your achalasia. And then for your spasm, you would see a corkscrew if you're able to do a chest x-ray during that spasm. With a barium swallow, you would literally see a corkscrew kind of shape for your esophageal spasm. Awesome. Next to her question. Couple of buzzwordy things in this question. Almost there, guys. Let's get the last few answers in. Awesome. Oh, wow. Okay, I didn't expect there to be this much variation, but good job to those who got esophageal SCC. Let's go into it. So GORD, Barrett's esophageal carcinoma, I'm just bundling them all together because, I mean, at the end of the day, they're kind of a series of, it's kind of a sequelae. So classic risk factors, hiatus hernia, smoking, obese, and essentially your clinical presentation is your real classic heartburn that's typically worse at night associated with a dry cough. As it starts to progress, you won't really see any history examination kind of findings on Barrett's esophagus. That's more of an investigation. Whereas with esophageal carcinoma, you could start to get progressive dysphagia plus your classic cancer B symptoms. So on investigation, for GORD itself, you're not too worried. You don't need to worry about really like doing any investigations. But if you're starting to suspect Barrett's or esophageal carcinoma because they've had it for a while, then you would do a gastroscopy. In terms of the management, I haven't really highlighted any of this because it's usually just symptomatic. So non-pharmacologically, raising the head of the bed could decrease your cough at night. Omeprazole or antacids are your best options for pharmacological therapy. And if you start to get a cancer, then you'll go down your cancer route. Some buzzwords to know. So these are important. These are very pathology kind of buzzwords as well. Literally, like PATH is 99% buzzwords, unfortunately. There's not much logic to it and not much kind of like differential reasoning. But if you see your kind of transition from stratified squamous to simple columnar, Barrett's esophagus, like alarm bells going off. Now, the easiest way to differentiate between adenocarcinoma and SCC is the location. Lower 1/3 of the esophagus, adenocarcinoma, middle 1/3 SEC. That's the best way to kind of differentiate depending on the location. And this is once again just where it's more common. So the location of your cancerous tissue is a really important differentiator for the type of cancer. And this is just like classic questions in PAP. So you guys might have seen these on like a couple of slides or some of your PAP quizzes, hopefully. All right, next is a Mallory-Weiss tear. Honestly, this is not too important. Alcoholic binge, middle-aged men, and then they have bloody vomiting. Essentially, it's caused by really forceful vomiting, and you kind of get like a laceration on the internal kind of surface or the mucosa of your esophagus. Kahoot. Last few answers. All right, cool. I kind of fabricated these answers a bit to just make them a little bit more difficult, but good work to those who answered azithromycin. As an explanation, here we go. So we're looking at a classic peptic ulcer disease case, and the main thing you're looking for is really your H. pylori. Some of the other symptoms or some of the other risk factors, sorry, that you need to be aware of are NSAIDs, classic NSAIDs, as well as smoking. For your clinical presentation, it's very similar to kind of GORD, as in you get your recurrent burning epigastric pain, commonly after meals. Important for determining the difference between the ulcers, however, is that duodenal improves with food, gastric is worse with food. For investigations, the main thing that you're really looking for are, and the main things they classically give you are really important H. pylori breath test. If it comes back positive, H. pylori. If you have a gastroscopy, this is another classic pathology kind of question where they give you a gastroscopy image. A few different things to consider, but really keep an eye out for whether you have an ulcer, if it's like severely ulcerated, etc., that kind of stuff. For management of peptic ulcer disease, really depends on their status. If it's a ruptured ulcer, then you're worried it's an acute abdomen. You do doctors ABCD, get them ready for surgery. However, otherwise, it's an eradication. Triple therapy is your classic one you might have learned in the second year DigiLab. Amoxicillin, clarithromycin, esomeprazole. Some buzzwords for you guys to note, once again, very pathology related are here. So if you have an ulceration with heaped edges, you're worried about intestinal type gastric adenocarcinoma. Your classic like linitis plastica is your leather bottle-like appearance. So that's your diffuse type. And then if it involves lymphoid tissue, maltoma. Next Kahoot question. So a lot of the kind of skill with EMQs is getting like limited information, like 80% of the information you need to make a diagnosis, and then managing to use your risk factors and stuff like that to pick the correct one. So I've kept information in this question slightly limited. Oh, but most of you got it right. So acute pancreatitis is the main one here. So pancreatitis, very classic presentation of burning epigastric pain radiating to your back. Really important one to look out for. In terms of your causes, it's I get smashed. Honestly, half of this acronym is absolutely useless, but the main ones are probably the first few letters. I for idiopathic, G for gallstones, E for ethanol, and then the second S is for scorpion bites. I don't know the rest. It's not really that important. But in terms of your clinical presentation, the classic things to really note are, as I said, burning epigastric pain radiating to back. You have your signs of retroperitoneal kind of retroperitoneal hemorrhage. So your gray Turner and Cullen sign, which is kind of your black kind of blotches on your front and side, as well as your patient is unwell and writhing. So they're in really, really bad pain. For investigations, your classic is serum amylase and lipase. That's pretty much diagnostic. If you get those results, it's pretty much confirmed pancreatitis. So keep an eye out for those. I've gotten a couple more questions in the chat. Sorry guys, I'm just going to keep this moving. If you can send me a message on Facebook or email, that would be ideal, just so that I don't run too far over time. Next is pancreatic cancer. So pancreatic cancer, the most kind of common one you guys will see is your head of pancreas cancer. And this is where you see Courvoisier's sign. So that is your pretty much painless jaundice. So when you palpate for a Murphy's sign, you don't really notice anything, but you can feel slight distension of the gallbladder. The second thing to look out for is Trousseau's sign, which is somewhat more niche. Not too many people have heard of it. Maybe you guys have, but it was something very new to me coming into third year. But essentially, it's kind of like migrating inflammation of your veins. Then you'll have your classic cancer B symptom of weight loss. And really the things you're looking out for on investigation are, once again, your kind of scans as well as CA19-9. CA19-9 is just a buzzword for pancreatic cancer. It's a type of cancer kind of biomarker that is important to know. And then in terms of management, the classic ones, ERCP plus like a Whipple's procedure are the main ones that you'd be considering. Pancreatic cancer doesn't show up as often on exams, but still pretty important. All right, that's all of upper GI. I think we're making okay progress. I'll keep things moving pretty quickly though. Moving on to lower GI. First things first, hernias. This is classic like year 2 anatomy kind of condition that you guys will hopefully know a bit about already. Essentially protrusional bulge, classically in the lower abdomen or around like the inguinal canal. A few different risk factors here. None of them are too, like the most important ones to really look out for are some things that can cause intra-abdominal pressure or pain, pregnancy, etc., that kind of stuff, or your incisions beforehand from previous surgeries. Classically, you'll get a bulge that like moves with coughing or straining, and then the main things to watch out for are if it's strangulated or incarcerated, then that's alarm bells for acute abdomen. So keep that in mind as well. Couple more people. I might just get ready to skip. Anyone got an answer? No? All right. Cool. So rotavirus is the answer. Let's take a look as to why. Gastroenteritis, classic. You all are very familiar with the disease, hopefully by now. A lot of you have probably had the disease at some point in your life. The main kind of things you're really worried about is dehydration, big red flag for dehydration, clinically at least. And then you want to keep an eye out for whether it's bloody or not. So diarrhea versus dysentery. Small bowel and large bowel kind of separation isn't super important. I don't think it's that important for you to know for your exams. Investigation wise, once again, you do your classic stool MCS. If it's a long-term presentation of diarrhea or bloody diarrhea, then definitely do a colonoscopy because it's less likely to be an infection. But in terms of management, honestly, just go hard on the IV fluids because dehydration is really bad, especially in younger kids. The best way to kind of differentiate between actual pathogens is really buzzwords. Unfortunately, faculty actually likes to ask some of these, so keep an eye out for some of these buzzwords once again, because they'll help you differentiate between the actual types of bugs once you've diagnosed a gastroenteritis, which is the easy part. So in this question, we were really trying to, most of you were probably tossing up between norovirus and rotavirus. So norovirus is most common in adults. It's your classic like cruise ship, there's an outbreak, that kind of thing. Rotavirus, most common in children. This patient was a kindergarten teacher, so it's likely that she was in contact with children a lot. That's kind of a brief explanation for this. Two that faculty just really loves for some reason, they just froth giardiasis as well as C. diff. So giardiasis, remember that you treat it with metronidazole. Steatorrhea is really important to note. C. diff is when you've been loaded with antibiotics during a hospital stay, and it's also called pseudomembranous colitis. You treat it with vanc and metronidazole. That's the important stuff to know. So for some reason, as I said, they do like really getting you to differentiate the types of bugs. So at the end of the day, if you know those buzzwords, it helps you differentiate. Moving on to the next Kahoot question. Let's see who's doing well. Jeff, you're killing it, Jeff. Not bad. So left lower abdominal pain, small bowel actions, few small bowel actions, low-grade fever. All right, cool. Let's keep it moving. 50, I will skip in 5, 4, 3, 2, 1. All right, awesome. Diverticulitis, well done, everyone. Let's take a look as to why. So diverticulitis is really common. 60% at age 60 is the easy way to remember it. Essentially, you're having kind of little outpouches forming in between your muscular layers in your GIT. So there's a couple of different presentations. Diverticulosis means you just have diverticular. So that's not too worrying, incidental finding oftentimes. Diverticular disease is one when it becomes clinically significant, classically due to diverticulitis. So this is usually when you get like a little fecalith, essentially poo gets stuck in your diverticular outpouchings, causing inflammation and eventually potentially causing an infection. So in Monash land, the classic presentation is your left lower quadrant pain, nausea, vomiting maybe, and a bit of a fever for diverticulitis. For diverticulitis, once again, you'd be considering the presentation of diarrhea/constipation, initially diarrhea and then initially constipation, and then later on diarrhea with hematochezia. Depends on the stage, depends on the type of diverticular disease, but left lower quadrant pain should really get your alarm bells ringing. Those are the main things. Remember lifestyle therapy, high fiber diet, and then for diverticulitis itself, because it's an actual infection, you'd want to consider antibiotic therapy. Next is appendicitis. You guys have got to be very familiar with this, classically presenting with right inguinal fossa pain, right iliac fossa pain, nausea, vomiting, and anorexia. And the pain classically migrates, and you can have rebound tenderness, you can have guarding, you can have cross tenderness or Rosving sign, I think it's meant to be. And classically, it'll be a younger patient, like 20s or teens, but it's important to keep an eye out for older patients as well. But you might just do some extra investigations if they were to come into your ED with this presentation. So really just get them ready for a lap appendicectomy as your management. Next condition is angiodysplasia. This is a bit niche. I don't think it's super important, but for some reason I've seen it before in exams. You get small kind of vascular anomalies in your GI tract. And when you do a colonoscopy, you can kind of see these really weird patches of like little telangiectasia are probably the best description for them. It's classically associated with von Willebrand's disease as well as aortic stenosis. In this case, with this association, it's called Hayes syndrome. The main things you're really looking out for are blood in your FOBT, and then your colonoscopy, and then you might do mesenteric angiography. But it's usually not super symptomatic, just random PR bleeds now and then. Moving on, keep things going. All right, I think that's good. I'm going to skip. Nice, mesenteric ischemia. Well done, everyone. So This is a classic differential for your acute abdomen. Mesenteric ischemia, not a huge presentation that you should know about. Just know the basics in terms of how to diagnose it. But acute abdomen is a classic OSCE station. Sudden onset 10 out of 10 abdominal pain can be generalized or localized, can be referred to the shoulder. The patient could be hypertensive, tachycardic. It all depends on the actual underlying condition. But the presentation of acute abdomen is really important for you guys to know, not only in exams, but as I said, OSCEs. And you want to do a whole array of tests depending on what you think it is based on history and exam. Classically, you'll need to give them analgesia because the pain is really bad and then get them ready for surgery. These are the kind of conditions you want to consider and the buzzwords to look out for. NSAID use during an OSCE or during an exam, think GORD, potential rupture, or a potential rupture of a peptic ulcer. Pancreatitis, if they're a heavy drinker or have gallstones. Mesenteric ischemia is your hypercoagulability history, which I think I made pretty clear in the question. And your classic presentation is really bad 10 out of 10 pain and a lack of other symptoms. So you're not too sure where the pain is coming from. Ectopic, if they're female, they are pregnant until proven otherwise. So always consider an ectopic. And finally, appendicitis, which we've just gone over. So as I said, classic OSCE station, make sure you screen for all of those buzzwords during your OSCEs. Next question on the Kahoot. Might skip when we get to 30 seconds, not to pressure any of you, but because I'm already under pressure to finish. Thank you for the influx of answers. See if we can get to 50. Let a few more people answer. Okay, I might skip. One more. No? All right, skip. Celiac disease. This is a bit of a weirder presentation. It was obviously meant to confuse you a little bit more, but let's take a look. Ooh, step bro, doing well. So celiac disease. As you all know, long story short, celiac disease is kind of literally like a gluten analogy, except some of the symptoms are a bit more severe and a bit more GIT focused. The classic antigen to keep an eye out for is gliadin, and in terms of your presentation, it's your long-standing kind of diarrhea, and then on top of that, it's anemia, vitamin, mineral deficiency. You don't usually get blood in the stools, so that's a good differentiator between celiac and IBD. The rash that you'll classically get, mostly on knees and elbows, but can pop up on your trunk as well, is dermatitis herpetiformis. If you start to get any weird symptoms that aren't very GI related, start to get your like autoimmune / room wheels turning. So celiac disease is more of an autoimmune condition than a classic surgical GI condition. So if you start to see a rash, really consider celiac disease as well as your stuff like IBD, etc. Your investigations, make sure you screen them for malnutrition. Iron studies are important because they might have anemia solely due to failure to absorb food properly in the GI tract. Anti-TTG is classic for your kind of tests. And then the most important thing is your biopsy. The buzzwords are increased epithelial lymphocytes, crypt hyperplasia, and villus atrophy. Really important to remember them in terms of pathology, as well as your final diagnosis of celiac disease. Moving on. So your erythematous mucosa is around the rectum and the descending colon, and the submucosa reveals ulceration. To get to 50 answers, I'll skip. Yeah, okay, I think I'll skip. Well done, everyone. UC was the correct answer. So IBD, let's very briefly go through it. IBD has two main presentations, Crohn's and ulcerative colitis. Crohn's more usually presents with just diarrhea, no blood, but you get your recurrent right lower quadrant pain because of the location of Crohn's disease. Ulcerative colitis, more commonly the left, but you get bloody diarrhea plus sometimes tenesmus. In terms of your investigations, the main things you're really looking out for are, number one, your fetal calprotectin is pretty specific for your UC. And then at the end of the day, everyone needs to get a biopsy. Crohn's and ulcerative colitis, while they might present similarly at times, once you do a biopsy, everything is really, really clear. In terms of your management, that's just a very brief summary of acronyms I like to use. So for ulcerative colitis, ACS, azathioprine, corticosteroid, sulfasalazine; Crohn's, azathioprine, methotrexate, infliximab. So yes, sorry, I've just copied and pasted management twice, but if there's a bowel obstruction, do surgical intervention. And then these are some of the extraintestinal manifestations of IBD. You do get these sometimes in your OSCEs. You should screen for them if you can. You do also get these sometimes in your actual exams. So make sure you look out for these kind of things in all patients who present with IBD. Here's a table that kind of separates the classic presentations on colonoscopy for Crohn's and ulcerative colitis. I'd recommend memorizing most of these because they are pretty important differentiators, and they really help out a lot when you've narrowed it down to IBD and don't know whether it's UC or Crohn's. PAP is once again very important. As I said, as the last slide has shown you, that's the best way for differentiating between the two conditions. Moving on, irritable bowel syndrome. This is classically a diagnosis of exclusion. Tummy pain plus diarrhea, but you have no idea what it is, and it's not too severe, you're really considering IBS. Classically, IBS is relieved after defecation, and you also notice kind of a change in stool appearance and bowel kind of habits, and there might be a dietary precipitant, different types of foods. The classic management for this would be your low FODMAP diet, but in terms of investigations, really rule out everything else before you diagnose IBS, because you don't want to miss a really significant condition like IBD whenever you're seeing this in a clinic. It's pretty much all there is for IBS. It's not too common on your exams, but an important differential too. Once we get to 50, I'll skip. Close enough. Bowel cancer, well done, everyone. Let's take a look as to why. So, bowel cancer, risk factors are important to note. If you have IBD, that significantly increases the risk of bowel cancer. Plus, genetically, FAP and HNPCC are the most important things to consider, which are kind of your genetic inheritance of risk factors for bowel cancer. On top of that, things like eating a lot of meat, like that guy in the question, obesity, smoking, important to consider. In terms of your clinical presentation, I tend to use the ABCDE. Commonly, it's asymptomatic unless it's picked up later on your FOBT. So it's not very likely that a patient will present symptomatic, but just in case, it doesn't hurt to know a very brief acronym to memorize that. In terms of your investigation, classically picked up on your FOBT, pretty much, you know, classic screening test. Everyone does it because bowel cancer is so like high prevalence. So it's important to consider the way diagnosing this whenever you see kind of cancer symptoms. The main thing to do is a colonoscopy and a biopsy to help you differentiate the types of cancer and if it's something else. And then you might also do something like a barium swallow, which could help differentiate. CEA is another tumor marker, important to consider. And finally, if you really want to flex during your OSCEs, then you might use DNM plus the Duke criteria, which is specifically used for bowel cancer. Some buzzwords are your types of genetic defects. So APC defect is a type of FAP is a type of APC defect, and HNPCC is a type of MMR defect. On pathology, the classic findings will be for FAP, just tons and tons of tiny polyps covering the entirety of the mucosa. Whereas in HNPCC, you'll have a few large angry polyps, but not as many. Now, this bowel cancer is a classic OSCE station. Whoops, I mean to go back. Is a classic OSCE station. So if you get a patient presenting with fatigue and lethargy and you're just not sure what it is, you should screen for everything. Obviously, the most common things to consider are things like anemia. But importantly, don't forget about cancers like bowel cancer. It's important that you screen for them too, to check for family history, to check for any symptoms, to check for any rectal bleeding, because it is very commonly missed when you're doing a fatigue history. Let's keep it moving with the Kahoot. Step Bro still in the lead. Honestly, if you read like the last sentence of this question, that's pretty much all you need, but this is an important presentation regardless. Wait for a couple more. All right, I'm gonna skip. Large bowel obstruction, classic signs of Haustra on your abdominal x-ray. So let's take a very brief look at bowel obstruction. The two different types are SBO and LBO. Really the best way to differentiate between them is with an x-ray. There's a lot of different causes. The main ones are probably going to be dynamic because you're not really looking at kids as much. Paralytic ileus is like your Hirschsprungs in kids. For dynamic, you're really looking at impaction, strictures, malignancies, volvulus and hernias. But the most common signs are going to be adhesions, hernias, and then the cancers. So you classically get your colicky pain. The most important things though are BNO, no flatus, and you can get delirium in older patients. So always consider bowel obstruction / constipation for delirious patients. For your investigation, really at the end of the day, as I said, AXR will help you differentiate between the types large bowel obstruction, which shows your Haustra, and if it's a volvulus, you'll see a kidney bean shape around your like sigmoid colon, and then SBO shows kind of more rings, which are your plicae circulares. Once again, throwback to year 2 anatomy. Awesome. Let's move on to quite literally the end of this lecture and the end of the GIT system. Let's finish off with the last couple of Kahoot questions. This might be the last question. Yes, we're going to make it. We're going to make it, guys, on time. Give you a couple more minutes for answers. All right, going to skip. Oh, okay. Let's take a look as to what went on here. I think most people said external hemorrhoids, which is good. Let's go into some more detail. So hemorrhoids, important to note, they're little inflammations of venous structures around the anus. They may be internal or external to the dentate line, and the classic presentation is your anal bleeding plus pruritus plus pain. The pain can vary depending on the type of hemorrhoid, internal versus external. For your investigations, you don't always need to do these. Sometimes a DRE is enough, but you definitely want to do, if you're worried about these being long-standing and a lot of blood, etc., you might need to consider a colonoscopy under anesthesia to consider IBD and just rule that out. But for the most part, it'll be just a history and examination. For your management, really brief management. I think this is important for you guys to know because it does come up in OSCE stations. So just know the basics of hemorrhoid management. But the important learning point here is internal versus external hemorrhoids. External is innervated by your ectoderm and is very, very sharp pain versus internal, which is more so like a dull, achy pain and isn't as severe. All right. Next is your perianal abscess or fistula, which we'll look at, which we'll consider for also anal presentations. So for your etiology or pathophys, it isn't as common as your like classic fissures plus hemorrhoids, but for your abscess and fistula, you do want to consider your like classic infections and abscesses around the anus. And in terms of chronic presentations, you have to be a little bit worried about a fistula forming in those patients. Most commonly, these are caused by infections, as I said, in the anal crypt glands, which are just around the anus, little outpouchings. Once again, your presentation is really just a subcut mass in your anal area. Most commonly, you'll see that on exam, but if a patient presents to you on history, make sure to screen them for infectious symptoms, plus pain on defecation, as well as when they sit down. So when you sit down, it usually means there's a little bit of a mass there versus your hemorrhoids and anal fissures, which are more so pain specifically on defecation. For them, you will want to do a clinical exam, but you'll want to do it under anesthetic because it's super painful. And those are the main things to consider for perianal abscess and fistula. Finally, here's just a couple of buzzwords for anal fissures. I haven't gone into them in too much detail. So sharp anal pain on defecation and a small amount of bright red bleeding. And importantly, you've got your chronic constipation. Anal fissures will almost always present with really chronic constipation, so your main management will be impacting their diet as well as giving them laxatives. Awesome. I am surprised that we managed to finish this all in time, but what I'd like to do is very quickly just give you a couple of tips for exams. Let's quickly see who won the Kahoot for purposes of satisfaction for this person. Toha came in third. Momo in second, and number one. Yeah, all right, this is a bit dramatic. Jeff, well done, Jeff. You win nothing, but hopefully a good mark on the exam. So let's get rid of this tab and finally finish this presentation off. So as you guys have noticed, I've gone over quite a lot of the important conditions for you to know, mostly focusing on pretty much everything on your matrix that is green and blue. Not too much on red conditions, but almost everything on GI is green and blue anyway. I've really tried to make it a bit more OSCE focused because I think you guys, honestly, like, it's been a crazy year. I'm definitely not envious of the position you've all been in, first year of clinical placements and then ending up with COVID. However, for third year, honestly, the most important thing that you guys should get good at is talking to patients, taking histories and exams. So I tried to make this relevant to that stuff. And if you get good at those skills, it does definitely help out in your written exams regardless. So what I've done here is I've just linked a Google Drive folder. Maybe I can click it and it'll take me somewhere. Yes. So this is just a Google Drive. I think I might have shared it with you before. I don't remember, of just some freebie resources. So some of this stuff is useful for your OSCEs. There's a bunch of EMQ questions, as well as like some practice OSCEs, which you guys might find useful, and a history of past OSCEs over the previous years. Also got a lot of these notes in Anki, which you guys can download from here if you are an Anki nerd like I am. But for the most part, this should be some useful exam preparation stuff. And when I upload these slides, you guys will be able to access it. I'll upload them right after. As I said, like, it's been a pretty crazy year. Hopefully you guys have gotten some time on the wards to get good at like your history taking and stuff like that. But for the most part, congrats on making it through the bloody global pandemic and everything. Hope you've all been staying safe. Prepare for your exams, do a bit of study, but make sure to take care of yourselves. And finally, if you have any questions at all, please feel free to reach out to me, Facebook, email. My email's at the first slide. So once again, when that's uploaded, feel free to reach out. For the most part, GIT is a pretty big component of the exam. So I think it's good for you guys to try and revise as much of it as possible. And it's also classic presentation in your OSCEs. I remember getting a hepatobiliary OSCE last year. Maybe you'll get something similar, maybe very different this year. But regardless, a little bit of preparation is definitely very useful. Otherwise, that is all for today. Thanks very much for your attention, participating in the Kahoot, and thank you for your patience. I'm very sorry once again that I was a few minutes late, but hopefully you guys get something out of these revision lectures. Thanks to Karan for organizing them. And as I said, reach out if there are any questions.
Thank you so much, Manoj. That was really good. Definitely much needed. Good fun with the Kahoots, Miss Preklin. So guys, we might be heading off for just a bit of a morning break, for a cup of coffee or whatever. We will have our sponsors from Mega having a quick chat later. So just don't leave, just stay here. If you want to go get coffee, that's fine. But yeah. And we shall join back at 10:50 for renal and urinary with Uven.